Thank you. Thank you. Good afternoon, everybody. My name is Mick from Trotsenburg, and as an obstetrician gynecologist, the main focus of my work is on transgender healthcare since about 25 years. I'm most grateful for the opportunity to give a webinar about the situation of elderly transgender persons. It's a strong statement indeed from EMAS to pay attention to the needs of a still widely neglected and also vulnerable group of persons living on the internal peripheries of society. Transgender persons are in need of life-spanning medical support. Now, gender affirmative treatment, the so-called transitional phase, is mostly done at younger age. To date, treatment often starts as early as 12 years with pubertal blocking agents. And in that phase, many specialties are involved. But after transitioning, there's a need for health maintenance, for healthy, also happy aging. And as a matter of fact, we do not know much about the needs of elderly transgender persons. There are only very few publications about elderly transgenders and also guidelines, as far as they exist, about transgender healthcare. They do not address the elderly trans persons. Now, what I'd like to do today is giving a short contextual introduction to transgender healthcare. And thereafter, I will go into detail on some items. By far, not all, because 1 hour is just too short for extensive deliberations. So I have chosen some items which I feel important. But at the end, please feel free to ask me whatever you want if I did not address items you are interested in. Misconceptions. That's the first thing, and something most of you might know. But I think it's of importance to stress the difference between these both topics, gender identity and sexual orientations. These entities lie close together, but are indeed different. Another point, and also a point of misconception, especially for medical doctors, are the endpoints of gender affirmative treatments. As a matter of fact, they are beyond medical perspective. For transgender persons, social affairs dominate. They are most important. And only on the second place, it's about physical problems. That is something important, and we need to know, and we definitely need to know the goals of our patients. And this definitions is all about one's gender identity, something we generally do not think about. It's just too self-evident. Only in early childhood and during puberty, questioning gender identity is accepted. And these are briefly the definitions of gender identity and the gender role. Gender identity, our deeply held internal sense of as a male or female or something together, a blend of both or neither. The gender role, how one should dress, act, behave based on one's perceived gender identity. Oops, that's too far. Right. Now, what is also of importance, I think, is the fact that gender identity has a spectrum dimension. One's gender identity is not rigid, but often shifts on a line. The border between what is named male and female is quite arbitrary, socially determined and dependent from culture, society, traditions, and it differs significantly between cultures and nations. For gender incongruence, formerly named transsexualism, transgenderism, gender dysphoria, it's more or less constituent that no pathology is found, neither genetically nor on the level of the gonads. Here you see the ovary, here you see testicles, nor phenotypically any disorder can be found. However, and that's one of the most compelling findings of the last, I think, 30 years, is the insight that important regions of our brain differs between male and female. In the preoptic area, which is part of the hypothalamus, there are several nuclei which develop slowly towards either a male or female pattern. And these nuclei are essential for both our gender identity and sexual behavior. These patterns are often not completely male or female, but appear in indifferent or show patterns with characteristics of both sexes. According to the studies of the group around Dick Swaap from the Dutch Brain Institute and Garcia Vilgueras and others, it is postulated that hormonal influences during late prenatal and early postnatal brain development may determine the sexual imprint of our brain. For example, the presence or absence of testosterone during the second half of pregnancy is believed to shape our brains towards male or female. To date, it's also believed that these brain characteristics do not follow the development towards the sex determined by genes. It's one of the explanations, it's just one of the explanations for gender incongruence. Of course, many other influences are needed, socially, relationally, emotionally, many others, name it, are necessary to come to the belief that there is an incongruence between one's body and one's gender identity. Now, the etiology of gender incongruence is not the topic of this webinar, but I think it's of importance to realize that the organizational effects of sex steroids on the development of our brain also determines gender identity. And these findings are indirectly confirmed by observations of mental health professionals who complained about difficulties in transgender persons already on cross-sex hormones. The psychotropic effects of sex steroids, namely, counteracted the efforts of the diagnostic process. These are already quite old studies. You might know that gender incongruence is no longer classified as a pathology. In the upcoming ICD-11, which is estimated to get into power next year or the year thereafter, in the ICD-11 it has been removed from the chapter on psychiatric disorders. To date, gender identity is regarded a human right, and one may self-determine whether he or she feels male or female. And in most European countries, medical treatment is no longer a prerequisite for a legal gender change. Just a few words about the prevalence. Quite a lot of studies have been published about the prevalence of gender incongruence, but most studies have had serious methodological frauds. To date, the WPATH, that's the World Professional Association for Transgender Health, this organization endorses numbers from a Dutch study. The representative cross-section survey in over 8,000 people at reproductive age from 50 to 70 were interviewed. And interestingly, 5.7% of all men and 4% of all women confirmed in this survey that they encounter difficulties, name it, with their gender identity and have serious doubts hereabout. But this survey confirmed more. 0.6% of all men and 0.2% of all women stated that they perceive gender incongruence and a significant discomfort hereabout, and expressed that the wish to undergo partial or even complete gender affirmative treatments. These are huge numbers, and they are not in line with the numbers we have encountered in our gender clinics. These numbers clearly demonstrate that many more people than generally expected feel discomfort with their gender identity and desperately seek support. Recent research by the Williams Institute from the university, I think the university clinics in Los Angeles, found that transgenderism is almost as prevalent among the elderly as the young. In that report, estimations said that 0.5% of Americans aged 65 or over, that's about 1 in every 200, identified as transgender, compared to 0.7% among younger people between 13 and 24 years old. But this was the only study about the prevalence of in elderly transgender or gender non-conformative people. There are many dilemmas in transgender healthcare, and this is certainly one. If we extrapolate these prevalence numbers on the population of any country, you may realize that a very big group of persons with obvious medical needs is widely ignored and has been left entirely up to itself. A survey from the USA and a subsequent study in the Netherlands revealed that generally doctors have hardly any clue, sorry, that's too quick, have any clue, as you can see here, about the situation of transgender persons, nor about the medical needs. And transgender persons themselves do not receive the medical treatment they are asking for. 50% of all doctors have no knowledge whatsoever about transgender healthcare issues. And that's a dilemma indeed. As a result of widely being neglected and underserved, both socially and medically, the trans community appears often mistrustful to healthcare services, avoids contact to medical services, disappears from follow-up, set up independent self-services, and medication is often obtained from black circuits and administered medically uncontrolled. So it does not wonder that we still do not know much about the needs and problems of transgender persons in general and elderly in particular. Now, if it comes to age, the question is, what age? It's helpful, and at least for me it was helpful, to consult what the WHO tells us about aging. WHO stresses that it is in fact impossible to understand aging and health without a gender perspective. From a physiological and from a psychological point of view, the determinants of health as we age are intrinsically related to gender. In case of transgender persons, it's of course very difficult to define whether health problems should be acknowledged from the perspective of the sex of origin or the sex one has chosen. If you look at metabolic issues or bone density, we mostly set out from the origin sex, but there is no agreement about this. That's only one reason why studies about transgender persons are so difficult to draw conclusions from. And unfortunately, elderly trans persons are neither addressed in the standards of care of WPAS nor in the Endocrine Society guideline on hormonal treatment of transgender persons. Elderly transgender persons are not a homogeneous group. There is a small group of patients who wish to start transition at very old age. Mostly, these patients do not ask for complete gender affirmative treatment with sex reassignment surgery, but are content with partial changes. For this group, treatment goals are mainly socially related, and physical changes are often not paramount. The biggest, actually exponentially growing group to date are those who underwent transition years ago and ask for continuation of hormonal treatment. Now, I will mainly focus on this group in this webinar. Another issue is the fact that elderly persons often suffer from chronic diseases, and we need to adapt the cross-sex hormonal treatment and sometimes also surgery to the individual health status and the individual risk profile. It is exactly this point which makes transgender healthcare so challenging, because transgenders state that gender reassignment or maintenance of feminization or masculinization is the most important thing in life and keeps them alive. Now, in this situation, it sometimes is quite difficult to convince patients that treatment needs to take into account the individual risk profile, and maximum dosages may be harmful rather than beneficial. This is also of importance. It's well acknowledged that transgender individuals and organizations seriously differ in terms of what constitutes the most suitable care with medical professionals. And in this context, it's of interest to have a short look at the suicide numbers of transgender persons. Among transgender persons, suicide or attempted suicide, which you see here, here, are tenfold higher than in the overall population. Here you see the number of the general population of the USA, according to the FDA, and here you see the numbers: 46% attempted suicide attempts and 4.7 in the general population. What is also of interest is a fact at the end of life. Opposite to the trends in the general population, suicidality is not a problem of elderly transgender persons. And this is a study I conducted myself with my colleagues in the Netherlands. Most deaths are not related to physical reasons, but due to either comorbid psychiatry, social isolation, troubled relationships, mobbing, discrimination, and hate crimes. Transgender persons suffer in many countries immensely from transphobia. And according to the FBI, LGBT people are more likely to be targets of hate crimes than any other minority group. Over 1,600 trans people have been killed between 2012 and 2016. What you see here is an almost six-fold higher mortality rate in trans women, this stands for male to female, compared to the general population. Interestingly, we do not see a significant difference to the general population in F2M or trans men. That's probably because trans men are, at least in Europe, much better integrated than trans women. Of course, it should be allowed to seriously consider whether treatment of elderly or very old transgender persons is reasonable. But unfortunately, I have encountered many arguments which I feel inappropriate. Often there is an underlying general disagreement with gender transition from colleagues who do not understand that the potentially irreversible results of treatment is not the point at all. Transgender persons do not have a choice at all. It's either transition or complete breakdown. On the other hand, yes, there are arguments to refuse treatment or discontinuation. For example, instability, a worrying individual risk profile, doubts about compliance and medication adherence, and many others. And we should remain a little bit self-critical. Nobody is immune to prejudices. Treatment at older age has always more risks, what makes it sometimes easier to reject treatment. But we should avoid age discrimination. And as the Royal College of Surgeons in Great Britain states, chronological age should not longer be used as a proxy for clinical factors. So, to be honest, there is uncertainty all over in transgender healthcare. Doctors are uncertain, and patients also, for different reasons, of course. As a matter of fact, many uncertainties derive from unknowingness at both sides and misunderstanding. This is, at least for me, not a surprise as long as transgender healthcare issues are not implemented in the curricula of medical students or part of the trainee programs of involved disciplines, what still is not the case. For example, in former times, a list of contraindications has been in use with almost all chronic diseases mentioned, both psychiatric disorders and metabolic diseases. But to date, we only use very few categorical contraindications. We consider adequate adjustment of concomitant diseases more important. And as a result of this policy, yes, we see postponement of treatment because we ask for proper treatment of other diseases prior to the start of cross-sex hormones. From all problems and possible concomitant diseases, I would like to focus a little bit more on 4 relevant issues for cross-sex hormonal treatment: venous thromboembolic events, cardiovascular disease, bone health, malignancies. Oh yes, and I also will mention polypharmacy. Venous thromboembolic events belong to the most serious risks of hormone treatment in trans women. It's widely acknowledged that age is an independent risk factor for VTE, and at advanced age, men are generally more at risk than women are. In this graph, the increasing risk for VTE at older age is nicely illustrated. Several explanations have been postulated. On one hand, aging is associated with an increased prevalence of conventional risk factors, development of new age-specific risk factors, and of course accumulation of risk factors with age. Hormone treatment in age-adjusted and risk profile dependent manner does not seem to be an independent risk factor. An observation in transgender VTE cases is that estrogen treatment is taken in dosages higher than recommended, and in that case, possible additional risk factors as smoking, immobility or transient immobility, and obesity might cause VTEs. Many retrospective studies confirm the risks of VTE for trans women. But most of these studies were published almost 20 years or more ago. Already in the late 90s of the last century, it became increasingly clear that both the type of estrogen and the route of administration influenced the incidence of VTE. At that time, ethinyl estradiol, EE, orally prescribed, was the favorite estrogen, causing at that time a 40-fold higher incidence of VTE compared to the general population. After a radical change of treatment policy with abandoning ethinyl estradiol and introduction of transdermal estradiol for trans women over the age of 40, VTE incidence returned to the range seen in the general population. To date, it is common use to prescribe transdermal estradiol either as patch or gel in elderly trans women and in patients with a relevant risk profile. There's ongoing debate about the pattern of cardiovascular disease in transgender persons. Men in all parts of the world have a survival disadvantage compared to women, independent of differences in lifestyle and nutrition. For a long time, this sex differences has been attributed to the presumed negative effects of testosterone on the cardiovascular system. But thorough analysis was unable to confirm this effect of androgens. In studies of cardiovascular morbidity and mortality, estrogen-treated transgender women are suffering more frequently from cardiovascular disease than women in the general population. On the other hand, transgender men receiving testosterone are not developing more often cardiovascular disease compared to women. Trans men under androgen treatment seem not to be affected. Interestingly, in trans women, not only atenyl estradiol has elevated the risk for CVD, but also 17-beta estradiol and a transdermal route of administration. However, the risk seems lower under transdermal application, but not significantly. Of course, pre-existing CVD requires very careful monitoring and adjustment of dose. I come to bone health. For maintenance of bone health, we know that sex steroids are very important. Hypogonadism leads to loss of bone substance in both sexes. Also in males, estrogen is the main factor for bone health maintenance. Low testosterone implies a lower rate of aromatization. For bone mineral density maintenance, estradiol levels of at least 40 picomole per liter are regarded as a minimum. The testosterone dose in aging transgenders might be lowered over time, but it should definitely be kept in the low reference range of biological male, that is about 8 nanomole per liter. In the course of time, a widening gap of bone mineral density between oral and parenteral androgen regimens has been observed. You see here the start and you see the gap widening. Green is intramuscular and the blue line is oral. Whereas BMD remains stable during intramuscular testosterone, cystanon for example, or Nebido, it appears to drop under oral andriol for example. Trans men taking oral medication should be regarded as high risk for developing treatment-associated bone mineral density loss. And for these subjects, therefore, routine DEXAs should be continued. This is because oral testosterone is only incorporated via the ductus lymphaticus, and fatty food is mandatory to enable resorption. Unfortunately, that is often not considered by our patients. Parenteral replacement seems to prevent from any shift in BMD in the course of time. Trans men with baseline DEXA within normal values and treated parenterally may be classified as low-risk group. Therefore, it's under debate to routinely repeat DEXA investigations. However, in most bigger gender centers, DEXAs are still recommended every 5 years in low-risk transgender persons. In the future, I believe that more attention will be put on discriminating high-risk individuals, and investigations will be performed according to the individual risk profile, rather than performing investigations for everybody. Yes, and for both sexes, of course, exercise, adequate vitamin D levels, and calcium intake are also of importance. In trans women, after a period of time of about 10 years, a lower BMD has been observed despite adequate estrogen levels. A presumed explanation for this observation is a reduced muscle mass as a consequence of androgen deprivation. Regarding bone health, complete discontinuation of hormones should be avoided at any time, as rapid and profound bone loss will occur. I come to malignancies in trans persons. And this issue is heavily discussed to date. Luckily, cancers are very rare in this population. The first report was published in 2008, and recently an extensive review was published. In both reviews, lung cancer associated with smoking, cancer of the intestinal tract, and hematological cancers were found, all not hormone dependent, and no malignancy appeared to be outside of the reference of the general population. For screening programs of the transgender community, there is, to be honest, not enough evidence to determine the appropriate type and frequency of cancer screenings. As we know, overscreening results in higher healthcare costs, high false positive rates, and often unnecessary exposure to diagnostic interventions. On the other side, underscreening results in diagnostic delay for potentially treatable cancers. Sorry, this is double. I come to the breast cancer entity. In peri and postmenopausal women under hormone treatment, breast cancer is quite a big issue. To our surprise, breast cancer in trans persons is quite rare and shows more resemblance to the pattern in men than in women. In analogy to current recommendations for cis women, again without evidence, we recommend estrogen-only therapy and no administration of progestins. Progestins are administered during the transition phase at the very beginning to induce the feminine sex characteristics these persons are desperately looking for. But anti-androgen therapy with cyproterone acetate is discontinued after 1 year. Also of importance to note is that trans men are also at risk because some glandular tissue is almost always left in situ for reasons of better looking thorax contouring. Many case reports have been published worldwide. In the Netherlands, where transgender healthcare is centralized in one center treating more than 95% of all transgender people, we conducted 2013 a review on 2,300 trans women and a follow-up between 3 and 30 years. And we, at that time, detected only one single breast cancer case. At that time, we already suspected a loss of follow-up. 2 months ago, a new review of the Dutch cohort was published with 2,260 trans women and 1,230 trans men, where the trans people cohort was matched with the nationwide cancer registry. This review detected 15 cases of invasive ductal breast cancer in trans women with a median duration of hormone treatment of 18 years. This was 46-fold higher than in cisgender men, but significantly lower than in cisgender women. Most tumors were of ductal origin and estrogen and progesterone receptor positive. In 1,230 trans men with a median duration of hormone treatment of 15 years, 4 cases of invasive breast cancer were identified. This was lower than expected compared with cisgender women. As a rule, we recommend self-examination and participation in national screening programs. Most programs recommend intervals of 2 years starting at the age of 50. Frequently, imaging of breast tissue in trans persons appears quite difficult. Many trans women underwent breast augmentation, as about 80% of all trans women do not have sufficient hormone-induced gynecomastia. On the other side, in trans men, residual glandular tissue is often not easily accessible for mammography. Therefore, in both trans women and in trans men, MRI is mostly warranted for proper imaging. Screening intervals of 2 years are under debate, but we feel it important that recommendations apply for trans people similar to the general population, as this policy improves compliance. Coming to the prostate, also an organ widely ignored in trans people. Cancer of the prostate is really at most rare, but probably it is underdiagnosed. Due to anti-androgen treatment and cross-sex estrogen, the prostate shrinks and often is hardly palpable. It should be part of any routine gynecological examination of trans women after sex reassignment to also pay attention to the prostate, which is easily palpable via the neovagina. On the other hand, PSA measurement is quite meaningless as levels are diminished. However, there are voices recommending PSA as this marker is simple and cost-effective. And these voices state that levels above 1 nanogram per milliliter under hormone treatment can be regarded as suspicious and requires further examination. Now, this is much lower than the cutoffs in the general male population, where only PSA above 4 nanograms is seen as an indication for further examination. For trans persons starting with gender affirmative treatment aged over 60, I think it should be mandatory to perform palpation and PSA measurement prior to hormone treatment. Another problem I'd like to address related to transgender healthcare, polypharmacy. This is one of the most striking problems of geriatric medicine. Estimates describe over 1/3 of elderly patients, you can see here also, 1/3 of elderly patients who fulfill the criteria of polypharmacy with more than 5 medications and at least one unnecessary medication. Polypharmacy should be addressed in transgender persons as over 100 drugs interact either with testosterone or estrogens, especially when there is hepatic elimination and not renal. So now when I come to my conclusions, the very first thing I want to address is the fact that regret is utmost rare. Note, regret with gender affirmative treatment is not the same as being not happy and socially isolated after transition. There are several studies which anonymously confirm these findings. Only recently, the Dutch cohort of over 8,000 transgender persons was reanalyzed with a median follow-up of more than 20 years, and 0.6% of all trans women and 0.3% of trans men expressed regret. We think these are very positive findings, and these are very low numbers compared to other centers worldwide. To further conclude, transgender medicine is far away from evidence levels of other disciplines. We have to admit that there is a lack of data about aging transgender persons. There's no consensus about medical management, nor about possible discontinuation at older age. There are potential sources of disagreement between patients and medical doctors. And therefore, there is certainly a big need for shared decision making, weighing the benefits and risk together. Expert opinion about cross-sex hormones at older age, it's not more, it's just an expert opinion. Yes, as little as possible, as much as necessary. There's a need for continuing follow-up, as we see a frequent loss of follow-up, as transgender persons often do not regard themselves as a patient. And last but not least, realize benefits are beyond medical perspective. Medical treatment is only support for social well-being. For transgender persons, these social side effects are more important and more worrying than medical side effects. Unfavorable passability, relational changes, discrimination, stigmatization, transphobia, loss of employment, restriction or loss of visitation rights for children. These are the problems transgender people encounter and make them suffer from life. With regard to trans men, we have so far no hints for harmful effects or necessity of testosterone dosage adjustment at older age. With testosterone levels in the lower normal range of biological men, conversion to estrogens is ensured, which is of particular importance for health maintenance. In trans women, the situation is slightly different. Studies clearly show an elevated risk for CVD, but however, the underlying mechanisms are still unclear. Therefore, it is recommended to adjust estrogen dosage according to the principle of, as I already said, as low as possible and as much as necessary. Serum levels should be enough for health maintenance. For example, 70 beta-estradiol should be above 40 to 50 picomole per liter in order to maintain bone health. And again, most important, regular follow-up. And here are the links to the standards of care of WPATH, the World Professional Association for Transgender Health, in the version Empower, and to the second version of the Practical Guideline for Hormone Treatment of Transgender Persons of the Endocrine Society. These are quite helpful reports for anybody being engaged in transgender healthcare. Yes, this is the end of my presentation, and I would like to thank you for your attention and your interest in aspects of transgender healthcare. This field is rapidly growing, with up to 14 disciplines involved. Today there was no time to touch on surgical aspects, although genital health maintenance in elderly transgender persons is also a hot topic. If you have questions in the future or comments or interesting clinical cases, please feel free to contact me. And here you see my email address. Thank you very much.
Okay, doctor, thank you very much for your presentation. And we have 3 questions already here. So the first question is, what is the recommended adequate dose of oral estrogen for elderly trans women, age from 50 to 60, with no significant comorbidity? If transdermal estradiol, what is the adequate dose?
The adequate dose for oral or for transdermal application?
For
or
oral.
For both? For oral. Now, as a matter of fact, I would not recommend giving oral medication in elderly patients. I would prefer transdermal applications in a dosage of between 50 and sometimes a little bit more, 100 microgram in 24 hours. But I have to admit that there are patients who refuse transdermal applications, either because there are dermal skin irritations or for other reasons. So you sometimes just have to do that. And in that case, I would prefer at an age of 60, 17, without any further risk, to give it in a dosage of 1 to 2 milligrams daily.
Okay, thank you. And the second question is, what is the guideline of serum hormonal profile, androgen profile monitoring in trans women or trans men?
The guidelines available do not make clear recommendations. They only state that we should recommend to our transgender patients screening programs as they are recommended for the general population. Now, from my point of view, this is a statement without any use. We should really we should follow the individual risk profile, and screening, we have to do screening only if that makes sense. So, for example, intestinal screening is independent of cross-sex hormonal treatment, and yes, I would strongly recommend to follow the guidelines here about. Regarding, for example, cervical screening in women, it does not make sense to recommend to trans women pap smears in this case, as there is no cervix. However, this group of patients, officially being women, they get invitations for this screening. Breast screening is more difficult. Now, what I recommend, yes, follow the recommendations of the nationwide screening programs for breast imaging, but note that mammography is much more difficult and imaging is not as clear as we wish with mammography in trans persons due to prosthesis or because the glandular tissue is just very, very small. And in that cases, we need to do an MRI. And the intervals are, yes, from 2 to 5 years.
Thank you very much. And we have the last question of this webinar. And the question is, if a trans woman would insist on continuing oral estrogen intake despite a significant thromboembolic episode, what is the ethical way to deal with this issue as a medical provider?
Now, if in case of a history of thromboembolic events, yes, we have to be careful. These are high risk patients. As a rule, I do not prescribe cross-sex hormones in the very first year after a thromboembolic event at all. After 1 year without any event again, I start, if necessary, I start very, very low with a transdermal application at a dosage of, for example, 25 microgram transdermally per 24 hours. And after 6 months, I would increase the dosage slowly, first 37.5 microgram, because you can cut the patches, and the maximum doses in that case would be for me 50 microgram transdermally, but never ever oral medication, neither ethinyl estradiol nor 70-beta estradiol, only transdermal applications.
Okay, thank you, doctor. And I see that we have one more question, so I believe it must be a last question. And the last question is, does a trans woman on either oral or transdermal estradiol need serum hormone monitoring? If yes, how often?
Yes, in all centers, it's recommended to have follow-up in intervals of at least 2 years without any risk. If there are additional risk factors, then you have to individualize the follow-up. But as a rule, I would recommend to have checkups every 2 years.
Okay, thank you so much, doctor. And this concludes the presentation and the webinar. Thank you so much for your wonderful presentation, doctor, and all the attendees for being here today. Thank you, everyone, and have a great rest of the day.